Good afternoon, students. Today's class is on glaucoma. So, at the end of the class, you should know to classify glaucoma and know about the symptoms and signs of glaucoma. What are the fundus changes in glaucoma? Visual field defects and various stages of glaucoma. Investigations employed to identify glaucoma cases. And how the glaucoma is treated, medical management and surgical management. So, what is glaucoma? Glaucoma is increase in intraocular pressure. The normal intraocular pressure is 10 to 20 millimeter of mercury. So, in glaucoma, there is increased in intraocular pressure more than 21 millimeter of mercury, along with optic disc changes and visual field defects. So, that is defined as glaucoma. Glaucoma are two types depending upon the angle of anterior chamber. So if the angle of anterior chamber is open, that is if it is 40 degree, then it is open. If it is less than 10 degree, then it is angle closure glaucoma. So open angle glaucoma is there and angle closure glaucoma is there. Open angle glaucoma is the primary open angle glaucoma. The predisposing factors, risk factors for open angle glaucoma includes age more than 40 years and race blacks more than whites, family history and inheritance. So if a sibling is having glaucoma, then you're likely to get glaucoma. Diabetes mellitus and myopics. Myopics are more prone to get open angle glaucoma, whereas hypermetropia, the eyeball is very small. Eyeball, axial length of the eyeball is small and they are more prone to get annular glaucoma. And thyroid disorders, those having thyroid disorders, they get open angle glaucoma. Cigarette smoking is a risk factor for open angle glaucoma. And steroid usage of more than 6 weeks. That's systemic steroids. They can increases intraocular pressure causing glaucoma. So the pathogenesis. Pathogenesis. Pathogenesis includes the aqueous outflow. There can be decrease in aqueous outflow or increase in aqueous humor production. The aqueous humor outflow includes trabeculum issue to episcleral vein. So there is increased resistance in episcleral vein can cause rise in IOP, intraocular pressure. Reduce aqueous outflow facility due to failure of aqueous outflow pump mechanism. There can be thickening and sclerosis of trabeculum issue with faulty collagen tissue. There can be narrowing of intertrabecular spaces and deposition of amorphous material in juxtacanalicular spaces, as like in amyloidosis. And then, the collapse of Kell's canal and absence of giant vacuoles in the cells lining it. All this can reduce the aqueous outflow. Epidemiology of primary open angle glaucoma, it affects 1 in 100 of general population age of more than 40 years. The prevalence is equal in POAG and PACG in Indians, and in Europeans and African Hispanics. POAG, that is open angle glaucoma, is the prevalence is more when compared to primary angle closure glaucoma. In Mongolians and Chinese, open Chinese primary angle closure glaucoma, prevalence is more. So, by definition, primary open-angle glaucoma is referred to as chronic simple glaucoma, which is bilateral, not always symmetrical diseases characterized by adult onset, IOP more than 21 millimeter mercury, and characteristic of optic disc cupping along with visual field loss. Symptoms includes uh, gradual painless loss of vision can be there, headache can be there, visual field defects, patient complains of black spots, that is scotoma, and frequent change in presbyopic glasses. So there's a delayed dark adaptation is there, and significant loss of vision and blindness. Signs of glaucoma, signs seen in glaucoma patients include uh, corneal haze, sluggish pupil because of the fluid collection, inflammation of your iris can cause sluggish pupil reaction. Intraocular pressure changes, repeated observation of IOP every 3 to 4 hours or 24 hours, and you look for diurnal variation and different patterns of diurnal variation with the diurnal variation of intraocular pressure. There's morning rise in IOP that does in 20 percentage of cases. Afternoon rise in IOP seen in 25 percentage of the cases, and biphasic rise seen in almost 55 percentage of the cases. Variation in IOP of over 5 millimeter of mercury ensures suspicious, and over 8 millimeter of mercury is diagnostic of glaucoma. So, what are the optic disc changes that are seen in glaucoma patient? So, in normal, so to know what is abnormal, we have to know what is normal. The normal optic disc, we got outer neuroretinal rim. There is a tissue between the outer edge of the cup and the disc margin. Outer edge of the cup and the disc margin. So this is the disc margin. A normal, centrally it is pale in color, whereas peripherally it is pinkish in color. So isn't true shows the thickness of neuroretinal rim. That is in inferior is more thicker. Inferior is more thicker than superior part of optic disc, and the temporal is more thinner compared to nasal. So you have to look for the isn't rule. And the cup disc ratio is important in classifying, in establishing glaucoma. Optic disc changes in glaucoma. So the cup disc ratio normally it is 0.1 to 0.4. If it is more than zero point 0.5 or more than 0.6, it is established glaucoma. 0.5 to 0.6 is disc suspect. When there is normal IOP, but there are fundus changes, there, then they are classified under disc suspect. In some patients, there can be physiological large cup can be there. In those cases, we need to compare the optic disc of both the eyes, and there's asymmetry between the two eyes uh, more than zero point 0.2. We call it as glaucoma. So in normal patient, the AMS asymmetry is less than 0.2. You look for the blood vessels. The blood vessels, central retinal vessels arises from the center and slightly, yeah, slightly nasal. So the neuroretinal rim is a fundus picture showing the optic disc. So when the light is thrown at the falls on the optic disc, the patient perceives as dark spot, that is called as that, which is physiological, since it is a optic disc is devoid of rods and cones. So it's called as physiological blind spot. The outer edge of the outer edge of the optic disc is called as optic disc, and the inner part, yellowish part, is the optic cup. So in between that, you got the neuroretinal rim. So neuroretinal rim consists of nerve fibers. Beyond lamina fibrosa, they continue as optic nerve. Early glaucomatous changes. The early glaucomatous changes includes look for the vertical cup disc ratio. So there is asymmetry of 0.2 between two eyes, and large cup, that is 0.6 or more, and pallor. You can see the pallor of the disc. Splinter hemorrhages can be there. Atrophy of retinal nerve fiber layer is seen in glaucoma. Advanced glaucomatous changes includes marked cupping, that is more than 0.8, 0.9. This thinning of neuroretinal rim, laminar dot sign. The lamellar dot sign is because of the exposed lamina fibrosa. There can be pulsation of the retinal arterioles. Nasal shifting of retinal vessels are there. This is called as the bayoneting sign. Glaucomatous optic atrophy. In glaucomatous optic atrophy, all the neural tissue of the disc is destroyed, and the optic nerve head appears white and deeply excavated. Here you can see optic disc fundus picture showing the optic disc where there is a large cup. The cup disc ratio is increased. Is more than 0.7. It's around 0.8. 0.8 is there, and you can see the bayonetic sign. Visual field effects. So visual field effects, it depends upon the anatomical basis of the retinal nerve fibers. So there's a bundle of fibers between macula and the optic disc, which is called as the papillomacular bundle. So these fibers are going to get affected only at the advanced stage. So there are arcuate fibers, superior arcuate fibers, and the inferior arcuate fibers. It is seen temporal side as well as the nasal side. The seen as well as the nasal side is there. So when these nerve fibers get affected, there is ischemia of nerve fibers, they are damaged, seen as a arcuate defect. Visual field defects are seen corresponding. So but the radiating fibers are there on the nasal side. Superior radiating fibers are there and inferior radiating fibers. The arrangement of the nerve fibers within the optic nerve. Arcuate fibers occupy the temporal portion of the disc and are most susceptible to damage. What are the visual field effects in glaucoma patient? It is isopter contraction is there initially, and there is a barring of or enlargement of uh, blind spot. There's wing-shaped paracentral scotoma, earliest clinical significant field defect. So, and there is cedal scotoma. That is cedal scotoma is paracentral scotoma joins the blind spot. Joins the blind spot to form sickle-shaped scotoma. Arcuate scotoma or germs scotoma. There is double or double arcuate scotoma. Superior, both superior arcuate scotoma is there and the inferior arcuate scotoma is there. So it's a ring or double arcuate scotoma. Picture D is a germ scotoma. So this is an arcuate scotoma along with the blind spot. On the nasal side, when the radiating fibers are involved, got the Ronnie's central nasal stem. Peripheral nerve defects can be, field defects can be there. In advanced glaucomatous field defects, when the PMB fibers are ischemic, when they are damaged, there is total loss of vision. In advanced stage, patient can go to tubular vision. From tubular vision, it can worsen to total loss of vision. So the criteria to grade glaucomatous field defects, it can be early, moderate, and severe glaucomatous field defects. Perimetry, using perimetry, you can know the visual field defects. Humphreys is there and octopus is there. So we got Humphreys perimetry central 30-2 test is there. So here in early defects, mean deviation, there is a mean deviation of 6 decibels. In moderate effects, it's around 6 to 12. In severe, it is around uh, more than 12 decibels. Corrected pattern, standard deviation. So there the corrected pattern depends upon correction with the age and correction with age, that is age related correction, that is corrected pattern, standard deviation. Early defect, it is a depressed to p-value less than 5%. In moderate, it is depressed to, again, in all three, it is depressed to p-value less than 5%. Pattern deviation is plotted and look for sensitivity in central 5 degree. So in early defects, it is no point or less than 15 decibels. Whereas in severe, both hemifields have points with sensitivity less than 15 decibels. So this is a gray scale, which is used to describe the visual field defects for a layman. The dark spots corresponds to the visual field defects. Investigations of glaucoma. So investigations include tonometry, central corneal thickness, diurnal variation test, gonioscopy, then Documentation of optic disc changes. Slit lamp examination of anterior segment. Where you look for any corneal edema, circumcorneal congestion, and the reaction of the pupil, the color of the lens can be seen, and look for angle of anterior chamber, whether it is open or closed, depending on the depth. Other investigations include provocative test, there is water drinking test, and nerve fiber layer analyzer. Tonometry intraocular pressure is measured with the help of an instrument called as the tonometer. There are two types: indentation tonometer, that is Schwartz tonometer, and gold standard one is Goldman's application tonometer. It is slit lamp mounted one. But Perkins application tonometer is there, and pneumatic tonometer, and pulse air tonometer, where pulse of air is jetted into your cornea that indents, applanates your center of cornea. The rebound pressure is calibrated, and it gives the intraocular pressure. And we got the tone of fairness there. So in Schwartz tonometry, you have to anesthetize the eye, and Schwartz tonometer is placed in the center of the cornea, and weight 5 grams and 7 grams. So the readings are calibrated, and then the corresponding, there's a chart which gives the corresponding intraocular pressure. Goldman's application tonometry, you anesthetize the eye using paraffin, and then the patient is asked to look straight, and conjunctiva is stained with fluorescent strip, and you look for the menisci, the upper menisci, tear menisci. There's upper menisci and the lower menisci, which is formed on due to biprism. So there's a biprism. You see a biprism here. So the applanation tonometer is smooth, and it is applanated at the center of the cornea. And, the rebound pressure gives the actual intraocular pressure. So here we can see Myers, when the biprism, center of the biprism is when it touches the cornea, two menisci are created, that is upper menisci, the lower menisci is there. So you increase this, you got a screw here where there is calibrations are there. You start with one, and then you increase it until the upper Meyer, inner end of the upper Meyer coincides with the inner circle or inner end of the lower Myers. So it has to be of equal size, both the upper Meyer and the lower Meyer. So that corresponding reading gives the intraocular pressure. When the stain is more, and the width of the menisci can be more. When if it is very thin, then it could be because of decreased staining of tears. Phonoscopy. So phonoscopy, this is used in phonoscopy lens this is used to see the structure of the angle of anterior chamber. But its root of iris, ciliary body span, scleral spur, trabecular meshwork, and valve line using a gonio lens. Perimetry is a procedure to estimate the extent of the visual field. You got a kinetic and static perimetry is there. Peripheral versus central field charting is done. Peripheral field charting confrontation method, you got then camping material is there. or photometry, got Goldman's perimetry, and automated field analysis, which includes freeze and octopus. The pictures of Goldman's perimetry, that's manual perimetry, and digital perimetry is there. Germ screen you got. These are some of manual perimetry. The automatic perimeter or computer assisted ones. The test visual fields by static method. Commonly used automatic perimeters are Octopus, Field Master, and Humphrey's Field Analyzer. The advantages of automated perimetry over manual perimetry. The interpretation of automated perimetry prints out field charts. And, testing strategies are there in programs. Uh, uh, Automated perimeter variables, background illumination, stimulated stimulus intensity. So the patient is given different intensity of light and size and duration. So when the patient sees the light, he is asked to click. The testing strategies and programs, they include supra-threshold testing. Threshold testing is there. And, one algorithm is a Swedish interactive threshold algorithm. That is CETA. Fast pack is there and full thresholds. So, what are the test programs used with static threshold strategy on HFA? It can be central field to look for central fields and peripheral field test is there and specialty test is there. For central, you got central 30-2, central 24-2, central 10-2, and macro test. Then peripheral, it is peripheral 30 or 60-1. Nasal step is there, temporal crescent is there. And special test includes neurological 20, neurological 50, and central 10 to 12 macular test is there. Hmm? Diagnosis. Primary open angle glaucoma is raised in intraocular pressure of more than 21 mmHg associated with a definite glaucomatous optic disc cupping and visual field changes is there. In ocular hypertension or glaucoma suspect, patient has an intraocular pressure more than 21 mmHg, but there are no optic disc or visual field changes. Normal tension glaucoma, low tension glaucoma. Here, the patient has typical glaucomatous disc cupping with or without visual field changes, and it is associated with the intraocular pressure below 21 mmHg. This patient has got cupping changes is there, optic disc changes is there, and but the intraocular pressure is normal. That's normal tension glaucoma. Management includes the primary aim of the treatment is to prevent functional impairment of vision. It is important to perform a good baseline evaluation with which future progress can be compared and documented. So when a patient comes, you do a slit lamp, you check for the visual acuity, intraocular pressure, slit lamp examination of the anterior segment is done, and the tonometry, which is preferably applanation tonometer, and optic disc evaluation. Optic disc evaluation is done. Undilated pupil in case of undilated pupil. Conioscopy is done and visual field charting is done. Perimetry is done. So severity of glaucoma can be graded as mild, moderate, severe by American Academy of Ophthalmology, where there is characteristic optic nerve abnormalities which are consistent with the glaucoma, and but the visual field is normal in case of mild glaucoma. In moderate glaucoma, there is visual field abnormalities are present in one hemifield, but not within 5 degrees of fixation. So in case of severe, the visual field defects are present in both hemifields as well as within 5 degrees of fixation. So the therapeutic choices includes medical treatment. You can give medical treatment, laser treatment is there, and surgical treatment. Do a filtration surgery. Medical treatment includes the basic principles of medical treatment of PAG is to identify the target pressure. So it is target pressure is that pressure by which you reduce the progression of the glaucoma. So that is the 25% of the intraocular pressure. So the treatment, it can be single drug therapy or it can be a combination. So first you start with a single drug therapy. One topically instilled anti-glaucoma drug is chosen, and depending upon the socioeconomic background, if it is ineffective, then you increase the dosage. If it is the IOP is not coming down, then we start with a combination. We go for combination therapy, where anti-glaucoma drugs includes beta blockers, then got clonidine and bromonidine, which are alpha 1 agonist, and you got topical prostaglandin analogs are there. Prostaglandin analogs, dorzolamide is present. That's carbonic anhydrase inhibitors topical. So monitor the therapy by disc changes, field changes, and tonometry. And you ask the patient to come on regular follow. So if it is patient is if it is mild, then you ask to come every 3 months. If it is severe, then you ask the patient to come. Moderate cases, more you can ask the patient to come every 1 month. And if it is very severe, then you can ask the patient to come by 2 weeks. So anti-glaucoma drugs classification includes miotics and some sympathomimetic drugs, that is adrenergic agonists, beta blockers, carbonic anhydrase inhibitors, hyperosmotic agents, prostaglandins, and calcium channel blockers. So the aim is to improve the drainage of aqueous humor and decrease the production of aqueous humor and reduce the ocular volume via osmotic gradient. So the parasympathomimetic agents, which is acting directly, or cholinergic agents, are pilocarpine, carbachol. These are pilocarpine is used in angle-closure glaucoma, and for laser iridotomy, prophylactic laser iridotomy in angle-closure glaucoma. Indirect cholinesterase inhibitors, which are reversible and irreversible, are there. Reversible includes physostigmine, neostigmine, and irreversible includes ecothiopate iodide. So these, they improve the drainage of aqueous humor. Prostaglandin analogs, that is latanoprost, it is given once a day. Sympathomimetic agents, we are direct sympathomimetic agents, which includes epinephrine. Then you got apraglutinin, remondin are there. These are also, they increase both, they improve drainage of aqueous humor and inhibit production of aqueous humor. Sympatholytic agents got beta blockers and guanethidine, 6-hydroxydopamine. There is all these inhibit the production of aqueous humor. Carbonic anhydrase inhibitors includes dorzolamide, which is a topical one, Orally, you got acetazolamide, which is the 250 mg BD, and osmotic agents. The osmotic agents and carbonic anhydrase, that is systemic carbonic anhydrase, they reduce the ocular volume. Mannitol, it has osmotic property, thereby reducing the volume, ocular volume. Glycerin and then alcohol is there. Prostaglandin analogs, the mechanism of action is increase in uveoscleral outflow. Indication is first line therapy. Preparation includes 0.005 percentage of latanoprost, which is a prostaglandin F2 alpha analog. The dosage is OD and additive effect is with timolol. So bimetoprost, latanoprost can be combined with timolol. Bimetoprost is 0.03 percentage, decreases the outflow, and again OD dosage. Travoprost is there, and you got onoprost isopropyl 0.12 percentage, which is given BD. Side effects includes flu-like symptoms, headache, muscle myalgia can be there, skin rashes can be there, and ocular side effects includes ingestion, that is hyperemia of conjunctiva, eyelash lengthening, and hyperpigmentation can be there, iris hyperpigmentation, and there can be anterior uveitis, cystoid macular edema can develop. Alpha-adrenergic antagonist, the mechanism of action is blocks the beta blockers in ciliary's process, thereby reducing the aqueous production. So it's a first line of therapy in patients who can't buy prostaglandin analogs. So the preparations, you got timolol 0.25 percentage and 0.5 percentage. It is a non-selective beta blocker, and it is contraindicated in case of bronchial asthma patients. And got levoguanolol 0.5 percentage, which is again non-selective beta blocker. Cardiolol 1 percentage and 2 percentage. There is a lesser incidence of bradycardia. So betoxolol 0.25 percentage and 0.5 percentage, which is cardioselective, that is beta 1 blocker, and the dosage is BD dosage. It's useful in asthmatics. So timolol, when timolol is contraindicated in asthmatic patients, you can give substitute with betoxolol. Side effects includes bradycardia, arrhythmia, heart failure, and bronchospasm can be there, especially in asthmatic patients. And CNS effects include depression, anxiety, drowsiness, disorientation, and other symptoms includes diarrhea, decreased libido, skin rashes, and alopecia. The ocular side effects includes conjunctival hyperemia. SPKs can develop corneal anesthesia. So contraindication is in bronchial asthma, COPD, heart block, and CCF, cardiomyopathy. Parasympathetic agonist is pilocarpine, dual action, carbopolisae. Mechanism of action is it increases the trabecular meshwork. Side effect includes bradycardia and increased salivation secretions. Ocular side effects includes miosis, which reduces the visual acuity in the cases of PPC, posterior polar cataract. There is impairment of night vision, and the broache, headache can be there. Myopia patient can come with myopia, keratitis, iritis, lenticular obesity, retinal detachment. All these are seen in parasympathomimetics. Carbonic anhydrase inhibitors, it increases the aqueous. So it is short-term therapy. It is used in acute cases. The dosage of Dorzox is 2 percentage. BD2 can be given twice daily or thrice daily. And there's additive effector with timolol. Brinzolamide 1 percentage is used. Again, it is can be given BD and TDS dosage. Side effects of carbonic anhydrase Inhibitors include metabolic acidosis, hypophilia, and anorexia. Cramps can occur. Ocular side effects includes induced myopia, stinging sensation, conjunctivitis, and keratitis. The laser treatment includes laser trabeculoplasty can be done using argon or diode laser. The indications are avoidance of polypharmacies, that is more than two preparations, and avoidance of surgery. So to avoid surgery, we can go for patient can go for a laser treatment. So the primary therapy in patients with the non-compliance to medical therapy. So there are more than two drugs, the compliance of the patient decreases. So you can go for argon and diode laser trabeculoplasty. The mechanism of action is to increase the outflow by causing shrinkage of trabecular mixture. The technique is 40 to 50 spots on the anterior half of trabecular mixture over 180 degree using a gonial lens. Complications includes acute rise of intraocular pressure, uveitis, hemorrhage, and peripheral anterior syncytial. Surgical management. Surgical management is indicated when the patient is not uh, responding to medical therapy and the laser therapy, or uncontrolled glaucoma, that is uncontrolled glaucoma, or non-compliance of to medical therapy, and availability of laser therapy, advanced diseases with a very low target pressure, they can go for surgery, early surgery. Surgery includes trabeculectomy, where fistula is created between the angle of anterior chamber and the subtenon space, which allows the egress of aqueous from anterior chamber to a drainage cup below the conjunctiva. So the procedure is to create a conjunctival flap that is limbus based or convex based. This will be limbus based. As a partial thickness of the scleral flap is raised, and you excise the trabecular tissue. Peripheral iridectomy is done. Peripheral iridectomy is done, and the closure, the scleral flap is closed with the 10-0 monofilament suture. Subconjunctival injection, dexamethasone and gentamicin. Dichlorouracil and mitomycin C can be used. Complication of trabeculectomy. Post-op, there can be shallow, and there can be inflammation of iris leading to iritis. Hyphema can be there, and ophthalmitis. Infection can uh, uveal cord can lead to endophthalmitis. Cataract due to accidental injury to lens. Ocular hypertension. Ocular hypertension, as I said earlier, you can see all the IOP is constantly more than 25 energy, but you don't have this for changes. The treatment includes again, it's very much similar to that of primary open-angle glaucoma, and the patient is assessed using very much similar to that of primary open-angle glaucoma. That is slit lamp examination, oblique distance perimetry. Treatment of normal tension glaucoma includes medical treatment, and systemic calcium channel blockers can be done. Trabeculectomy can be done. Monitoring of systemic blood pressure. With this we finish glaucoma. and covering primary open glaucoma, normal tension glaucoma, and ocular hypertension. Thank you.